The neck, a compact, complex highway of vital structures. For a medical student, palpating a neck mass can be a moment of high anxiety. Is it a benign lymph node, a congenital remnant, or something more sinister? Today, we're building a diagnostic compass, a systematic approach to navigating the differential diagnosis of a neck mass. We'll move from the most common to the most critical, using anatomy and patient history as our guide. Our first and most powerful tool is anatomic localization. We mentally divide the neck into triangles, the anterior and posterior triangles, but for practicality, we think in clinical zones. The location of the mass immediately narrows our differential. Let's start with the most common presentation, the lateral neck mass. In an adult, a lateral neck mass should be considered metastatic squamous cell carcinoma until proven otherwise. The primary source is often occult, hiding in the mucosa of the upper aerodigestive tract, the nasopharynx, oropharynx, larynx, or hypopharynx. This is not a diagnosis to miss. But of course, it's not always cancer. Our next most common culprit is reactive lymphadenopathy. This is typically tender, mobile, and associated with signs of infection, a recent URI, pharyngitis, or dental issues. In younger patients, we must think of viral syndromes like infectious mononucleosis from EBV or CMV, presenting with bilateral lymphadenopathy, fever, and fatigue. And we cannot forget granulomatous diseases. Tuberculosis lymphadenitis, or scrofula, often presents as a matted, sometimes fluctuant mass in the neck. Cat scratch disease, from Bartonella henselae, is another key player. Now, let's move down to Zone 1, the supraclavicular fossa. A mass here is a red flag. A left-sided node, called Virchow's node, is classically associated with gastrointestinal malignancies, such as gastric cancer. A right-sided node may suggest intrathoracic malignancies like lung or esophageal cancer. This is a signal of pathology from below the clavicles. Next, the anterior midline neck. Here, think thyroid. A mass that moves with swallowing is almost pathognomonic for a thyroid nodule or goiter. Just below the thyroid cartilage, a thyroglossal duct cyst presents as a smooth, cystic mass that moves with tongue protrusion, a classic exam finding. Below the hyoid bone, we consider a dermoid cyst, a firm, subcutaneous lesion. Now, let's talk about the age of the patient. This is our second key filter. In children and young adults, congenital and inflammatory causes dominate. Congenital causes include branchial cleft cysts, often found anterior to the sternocleidomastoid muscle, and thyroglossal duct cysts in the midline. Cystic hygromas, or lymphangiomas, are soft, compressible, and often in the posterior triangle. Inflammatory causes are dominated by reactive lymphadenopathy. While less common, lymphoma is a serious consideration in this age group, often presenting with persistent, rubbery, non-tender nodes and B symptoms, fever, night sweats, and weight loss. In the adult over 40, the calculus shifts dramatically toward neoplasia. A new, painless, firm, progressively enlarging neck mass must be considered metastatic cancer or lymphoma until rigorous investigation proves otherwise. So, how do we apply this? With a meticulous history and physical. History should include duration. Short duration suggests infection. Long duration suggests a congenital or indolent neoplasm. Associated symptoms: sore throat or fever point to infection. Atalgia, hoarseness, dysphagia, or hemoptysis are alarming red flags for malignancy. B symptoms suggest lymphoma, and always ask about travel and exposure, TB exposure, cat exposure, and dental history. Physical exam involves inspection for size and location, palpation for tenderness, consistency, and whether it is mobile or fixed to underlying tissue, and auscultation for a bruit, which suggests a vascular tumor. And finally, determine the character of the mass, solid versus cystic. A simple cystic mass in a young adult at the anterior border of the SCM is almost certainly a branchial cleft cyst. A solid, irregular, fixed mass in a 60-year-old smoker is metastatic cancer until proven otherwise. Let's synthesize this into a clinical approach. First, localize the mass. Is it anterior, lateral, or supraclavicular? Second, characterize it. Is it solid or cystic? Tender or painless? Mobile or fixed? Third, contextualize the finding. What is the patient's age? What are their risk factors, such as smoking or alcohol use? What are their associated symptoms? This systematic method turns a confusing finding into a directed diagnostic pathway. It tells you when to start antibiotics for presumed lymphadenitis, when to order an ultrasound for a thyroid nodule, and when to urgently refer to ENT for panendoscopy to find a primary cancer. The neck mass is a puzzle, but you now have the map. Use it wisely.